Hello and good evening. I'm Chris O'Flaherty with Oculus, and on behalf of Oculus, I'd like to thank everybody for joining us this evening for tonight's clinical webinar, Mastering Dry Eye Step by Step. If you have any questions during the webinar, I'd encourage you to enter those questions into the text box on the right of your screen. We'll do our best to get those questions answered tonight or in the days following the webinar. Our speaker this evening is Dr. Arthur Epstein. Dr. Epstein is the co-founder of Phoenix Eyecare, and he heads the practice's Dry Eye Center. He also serves as its director of clinical research. Dr. Epstein has presented at over 1,000 lectures worldwide. As well as being a highly regarded speaker, he is a contributing editor for Review of Optometry. He's executive editor of Cornea and Contact Lenses and chief medical editor of Optometric Physician, the first e-journal in optometry. And here at Oculus, we're certainly excited that Dr. Epstein could be here to share his knowledge and experience. So at this time, I'd like to welcome Dr. Arthur Epstein.
Well, thanks, Chris, and thank everybody for taking time out of your busy schedules and out of your family time as well. I know it's dinner time back east, and I appreciate your being here. I think you're going to find this an interesting presentation, or at least I hope so. It's really focused on a distillation of what I do in my own practice. And even though I really focus extensively on dry eye and ocular surface disease, I think it's very applicable to pretty much any practice, and that's really the base idea. It's a relatively systematic approach to identifying, diagnosing, interacting with and communicating with, diagnosing and treating dry eye patients. As you probably have seen numerous times in CE lectures, these days we have to disclose relationships. Those of you who know me, I pretty much recognize that I say, I won't say necessarily pretty much whatever comes to mind, but I certainly say what I think. And these relationships have not impeded that in any way. In fact, most of these are companies that have been kind enough to sponsor lectures like Oculus is doing this evening, or sponsored research in our practice and so on. But these are my disclosures, and let's get to the meat of the presentation. So the bottom line is, even though this is a step-by-step approach to managing dry eye in your own practice, it really is also a little bit of an entree into developing and managing your own successful dry eye segment within your practice. Whether it's a standalone dry eye practice, whether it's a small focus in a primary care practice, either way it works. This works in independent professional practices. It also works in commercial or corporate settings as well. The first thing, and I think the most important thing, is that things have changed dramatically over the recent past. Our understanding of dry eye is so different today than it was just a few years ago that it's quite remarkable. And in fact, many of our colleagues haven't gotten the memo, if you will, which creates a tremendous opportunity for you to truly excel in managing patients who are a group of individuals who are underserved. In fact, we're seeing more and more dry eye than we ever did before. I think the most salient aspect of this shift in thinking is that we've gone from this relatively simplistic three-layer symptom-based approach to managing dry eye and ocular surface disease to recognizing that the tear film is exquisitely complex and that most of our patients, and I'll share some data on that in just a minute, most of our patients actually have Meibomian gland dysfunction as the root cause of dry eye, tear instability, and a good deal of ocular surface disease. And I'm going to be going through that in significant detail. So the goal here is, yes, to treat symptoms. You know, you can't ignore the symptoms. You can't expect someone to go to a dentist, for example, in excruciating pain, and the dentist to say, well, I figured out what's wrong and I can keep it from getting worse and keep it from decaying further, but I can't really help your discomfort. That obviously wouldn't work. And dry eye patients come in and they seek help in terms of alleviating their symptoms. I think that's very important, but also recognize that dry eye is a progressive disease and you can intercede and stop that progression. And I believe in many cases reverse the progression as well. So the first step, and I think the most important, is identifying the patient, and we use a survey similar to this, an OSDI or the speed survey. Both are available online, and at no cost. We print these out using the color printer, and I use both because the OSDI really focuses more on aqueous deficient dry eye patients, and the speed is actually more effective at identifying evaporative dry eye patients, which really are the bulk of the patients that you'll be seeing. It also quantifies the patient's experience, so you can gauge how much success you've had in improving the patient's dry eye. And in many cases, patients don't even recognize how successful you've been at helping them, and having a numerical analysis or a numerical survey of their symptoms and seeing the change can make a very, very big difference for them. Dry eye can be tedious in terms of testing, so we rely heavily on our staff. We have a trained staff that performs a good deal of the technical examination of the patients using some of the latest technology, and I think that's very, very important because the patient interacts with the staff who are really motivated and empowered by helping diagnose dry eye and using this technology. So for us, it's a real big win-win. Many of you are familiar with tear osmolarity. This is certainly a screening tool, and we're really beginning to wrap our head around this as an entry as well as a diagnostic aid. So I think that's among the many things that we do. So patients will typically get osmolarity testing. Patients will then be brought into a dry eye testing room for us, and we have LipiView and LipiFlow technology. We've had it for well over probably about 1.5 years, almost from the beginning of our practice, which is relatively new. In fact, we just had our second anniversary or our birthday. LipiView 2 actually has an interferometer, but we still have the original LipiView, and we use that for measuring. Oh, I'm sorry, a Meibography, I should say. But we use the LipiView for measuring lipid layer thickness as well as for assessing blink dynamics, how frequently the patients blink and how complete the blinks are. My favorite instrument, and I call it the Porsche of instruments, I liken it to my favorite car, which is a 911, is the Oculus Keratograph 5M. I absolutely love this instrument. It is an entire dry eye testing suite in one device. It does non-invasive breakup time, Meibography, tear meniscus height, tear film scan, tear dynamics, lipid layer assessment, and it also now generates this really amazing report, which is continuing to evolve, which is a very, very important piece of education for the patient because they could take it with them. And we'll talk more about education throughout this entire lecture. Meibography is critically important. Here you see relatively normal Meibomian glands. The upper glands are thinner than the lower glands. They are fairly long and thready. If you look closely, you can see the acini. I tell patients it looks like grapes with a central duct or grapes with a central core. And you can see that even more dramatically in the lower lid. This is a relatively normal patient, and this is typically a patient that would be comfortable and relatively asymptomatic. Here we're beginning to see some changes. The glands are missing. If you look over towards the, not sure if you can see my pointer, but if you look over towards the lateral side over here, and as well as over here, the glands are missing. They're also truncated on the inferior portion of the inferior lid, rather. You can see glands are missing here, and these glands are sort of convoluted and thready, and you have a little bit of gland truncation. So this is moderate Meibomian gland dysfunction. Here we have fairly significant Meibomian gland dysfunction. You can see these these glands have atrophied significantly. You can see very little healthy gland tissue here. Most of it's missing. You can see vascularization in here as well. Most of the glands are gone. Not completely, but most are gone. And here you can see in this eye, these glands are almost completely gone. Sadly, this is a 23-year-old patient who is absolutely miserable and is extremely difficult to manage. What's great about Meibography is that I tell patients it's not an X-ray, but like an X-ray, and they can see their own glands, and I explain how important the glands are, and I'll get to that in just a minute. But when they see something like this, where their glands are atrophied and barely there, and over here the glands are almost totally missing, they know that they have a serious problem that needs to be managed and treated. LipiView 2 has dynamic Meibomian imaging. It's basically another way of imaging the Meibomian glands, and if you have a LipiView system, this might be an option. Meibomian gland dysfunction can be graded. I don't want to get into that, but you can see it goes from normal healthy glands, grade 0, to grade 4, and actually this is, I think, an optimistic grade 4. Non-invasive automated breakup time is a phenomenal tool. Tear stability, and I talk to patients about the importance of tear stability, is critically important. And when we're looking at fluorescein breakup, it's selfish. We see only the image for ourselves. We don't really show it to the patients, or at least not in real time. What's great about this is you can hit this little video button over here, and the patients can actually watch their tear film breaking up, and the summation is here in this nice chart. Green is obviously better than yellow, which is better than orange, which is better than red. So it measures the onset of breakup as well as the amount of breakup that occurs over the surface of the cornea. And that was a fairly normal patient, and here we have a patient that has significant corneal distortion and very, very rapid breakup. You can see 2 seconds and change, and we see a significant portion of the cornea is affected by breakup. And I really look at this more as an assessment of tear film stability. The less stable the tear film is, the more uncomfortable the patient's going to be, the more the surface of the eye is going to be exposed to the hydrophobic atmosphere, and the more the architecture of the underlying corneal tissue is going to be altered and damaged, and discomfort is a problem for most patients. So after going through these tests and a few others, the patient is brought into the exam room and sat in a chair. I introduce myself. I go over the history with the patient. I go over the questionnaire. I look at their general health history as well, and I ask them what brings them in and what their symptoms are, and we go through that in some detail. And patients are very forthcoming. The average patient in my practice is someone who's seen between 4 and 6 doctors in the past few years and has come in still complaining of significant symptoms. And they're really desperate for relief, many of these patients. And I know some of you are thinking, well, I don't see those kinds of patients. I don't see that many patients. And I think you'd be surprised at how many patients there are that have significant dry eye that disturbs them. And in fact, how many patients there are that don't even realize how disruptive their dry eye or ocular surface disease is. And I typically engage them by starting with a simple question, why do we have tears? And I tell them that any engineer who is designing a system would not make the system wet because it's hard to manage. You have to deal with gravity. You have to deal with evaporation. The only solution to the problem of seeing was to create a wet system, because a wet tear film creates a smooth, regular surface and allows us to see, and in fact it's a very effective survival strategy. So patients understand that the reason why they have tears is primarily to see, and that the tears are an important element in the overall dynamic of visual performance. A lot of patients will say, well, my eyes are always tearing. I don't understand why my eyes are tearing. And I explain that we have the equivalent of a built-in eye wash station like you'd see in a mechanic shop or a factory, and that when the eyes are irritated or damaged, that tearing is a natural way of clearing away the irritant, and it's a sign that that system is working. But I tell them that I'm not really interested in that system because I know it's working. I'm interested really in the system that is structural, that allows the tears to be structural and protective and functional and allows them to see well. Now, you're all familiar with the 3-layer tear film that was originally described by Wolf in 1951, and most of us were trained in that way. And we think of things in that way. We think of the mucin layer as distinct from the aqueous layer and, again, as distinct from the lipid layer. But in truth, the updated tear film model is really dated at this point. And, you know, the concept of the elements mixing in together is very valid, but not really effective in addressing patients' problems because it doesn't really get to what is essentially the root of their issues. So for patients, I use the house analogy, and I explain that the cornea, very much like the skin, is essentially hydrophobic. I don't use the term hydrophobic, but I tell them it repels water, and it wouldn't be very effective in maintaining the tears structurally and in contact with our eye. So we have a layer that transforms this hydrophobic surface into one that's water-loving and helps hold the tears in place, helps maintain tear film stability. And that we have an aqueous component that's actually viscoelastic and protective, and we actually have a roof, very much like the roof of a house, that's made up of a complex lipid that's tacked in place by specialized lipids called phospholipids. I obviously don't go into that much detail for most patients, unless they're engineers, of course, and that the lipid layer serves as an evaporative barrier and also helps stabilize the house very much as a roof would. And I tell them if there's a hole in the roof and water gets in, it will damage the walls and eventually damage even the foundation. And likewise with an eye that has an incompetent or a non-cohesive lipid layer, moisture will escape and the entire tear film will collapse and lead to symptoms like the ones that brought them in to see me. So we recognize now, and the literature validates that the vast majority of patients who have dry eye do not have aqueous deficiency. They don't have primary inflammation or a host of other things that we thought in the past. What they have is an evaporative issue, either as a primary or a contributory cause, or a contributing cause, I should say, of their dry eye. And that includes patients that have rheumatoid arthritis-related dry eye or Sjogren's syndrome. Very often, evaporative issues are the straw that breaks the camel's back for these patients, and it also can be a very, very effective tool in bringing them back from the brink and making them comfortable again. And again, that's even patients who are aqueous deficient. So I continue the exam by performing a physical exam, and we first assess the lids, and here you can see plugged Meibomian glands. Normally you wouldn't see Meibomian glands at all. We do diagnostic expression, which obviously anybody can do. It doesn't require instrumentation, just a fingertip. And you can see here this beautiful, pristine, baby oil-like clear fluid coming out of the Meibomian glands on light pressure. And what you're trying to do is emulate the pressure, the forces that would be occurring with a normal blink. So I think that's very important and very helpful. As Meibomian gland dysfunction occurs and progresses, the oil goes from this clear, very loose fluid to more opaque and thicker as the oil becomes increasingly saturated and stagnant. Less is produced as it becomes thicker because blinking isn't very effective at expressing it. And eventually it becomes a semi-solid, then a paste, and eventually it becomes almost waxy and hard. And as inflammation occurs in the glands and the glands become lost, they suffer from atrophy, and we often see lid notching as a sign of that. And I think that's important. It's also very important to recognize that when you just do a normal slit lamp exam, you're going to miss many patients that have Meibomian gland dysfunction, as many as 50%, because you have patients who look pretty much normal, but if you don't do diagnostic expression, you're not going to see that they're non-functional, that their glands are completely obstructed and that they're filled with this waxy paste-like material. So non-obvious MGD is a very, very important diagnosis in the overall dry eye equation. Now, the ocular surface exam, I describe that really as a fluorescein and lissamine green, but obviously you're looking at the ocular surface with white light as well. I won't go into the mechanism of how fluorescein works, but I will tell you that in addition to looking for staining patterns, I look for breakup time, which I corroborate with this non-invasive automated breakup time, which is performed by our technical staff. So breakup time you're familiar with, you know, count 1 Mississippi, 2 Mississippi, and look for a breakup. Now, if you see breakup in the same area over and over again, what it tells you is the architecture of the cornea has been damaged or disrupted. In other words, the glycocalyx, which transforms non-wetting into wetting, has been disrupted. The microvilli are probably damaged, and the hydrophobic cell membrane is exposed, and breakup occurs because the tears won't adhere to that area. And if it happens again and again in the same area, that confirms that. If it happens sporadically in different areas with each time you do it, each time the patient closes their eyes and opens and you begin counting, it tells you that you have an incompetent lipid layer due to insufficient lipid. So that's diagnostic in and of itself. And I think that's very, very important. So breakup time is a very, very important tool for diagnosing ocular surface integrity. So fluorescein staining is important. Lissamine green is great. Lissamine green staining is great for showing keratinized tissue, but also for highlighting the line of marks, which is the buildup of epithelial tissue over the mucocutaneous junction, or caused by the mucocutaneous junction. So one of the things that we often miss for our dry eye patients is contributing factors, and one of the contributing factors that is a major issue for a not insignificant number of patients is exposure. You'd be surprised how many dry eye patients have leg ophthalmos or nighttime exposure, and for most of the patients, they're unaware of it. Some will say, oh, I know I sleep with my eyes partially open, or my husband or wife has mentioned it to me. It's important to check for corresponding staining, but probably even more important to check for the Bell's phenomenon. And Bell's phenomenon is the eyes rolling up and out on forced closure. Basically grab the lids and have the patient attempt to close their eyes as forcibly as possible. And if the eyes don't roll out and they have that staining pattern, that needs to be addressed, which we'll talk about in a minute. So after getting all this information, after going over the Meibography and the non-invasive breakup time, and then doing the physical exam, I go over all of the findings with the patient. Now recognize that Meibomian gland dysfunction, as I said before, is the bulk of issues for most of the patients I see. Probably 90%, maybe even a little bit higher in my practice. It's a source of tremendous misery. This is a flow chart that I use, and it changes from time to time. I have decreased the number of drops I use by probably at least 50%. I'll talk about nutrition. I'll talk about Avenova. Blink training is important. Debridement of Marx's line, or that mucocutaneous junction, is important. Heat mask is helpful. And we'll talk about getting to the bifurcation, or the fork in the road, when patients have significant obstruction that needs to be cleared. Evaporative dry eye is the bulk of it, as I said before, close to 90%. And aqueous deficient dry eye, that I thought, and I think most of us thought, was the primary cause of dry eye, is actually significantly less. And for those patients, drops are important. Nutrition as an anti-inflammatory aid, omega-3 is important. Plugs, perhaps. I don't use them very much, and anti-inflammatory steroids and so on. So for drops, what I use in descending order, I consider Blink to be the new entry-level drop. I don't use very much of it because, frankly, I don't see patients that need something that's just palliative and not overwhelmingly functional, if you will. I actually prefer Sustain Ultra because many of the patients with aqueous deficient dry eye have significant surface disruption, and hydroxypropylene sticks to the cornea, creating an anchor point or a tether for what is a mucus or a mucin replacement. So it creates a matrix that's similar to the way mucin works. It's a mucomimetic. So that's my typical go-to drop. For patients that can't tolerate sustained balance, I use Refresh Active Advanced. advanced. Fresh coat I use for severe or moderate severe patients with good success, and Sustained Balance is really my go-to product. Probably the single biggest breakthrough we've had in dry eye and ocular surface disease over the past year has been the introduction of Eye Lid Cleanser, now called Avenova. And what's really great about it is that, number one, it kills bacteria. Staph overpopulation is rampant with meibomian gland dysfunction because of the increased food source. That congealed, saturated meibum is a food source for staph. They produce exotoxins to kill off their neighbor. The strong survives, but also gets in the eye and produces injection, which is a problem for those patients, and irritation. And they also produce enzymes which allow penetration into tissue, but lipase is the one that really is of greatest concern because it gets into the tear film, mixes with salt, and produces soap, saponification, which you are familiar with. Here you have a typical MGD patient that's moderate. You can see the plug glands, telangiectatic vessels. That lens is literally stuck to the eye because it's so dry from evaporation. And here we have saponification or soap making. So whether it's lipase getting in and not producing soap for whatever reason, or soap being produced, what does soap do? What does lipase do? It breaks down lipids. So even if you have some lipid in the tear film, staph bacteria break it down and actually create evaporative dry eye issues. So Avenova is just phenomenal. I have the patients use it twice a day, and we've had phenomenal success with it. It took me a while to zone in on appropriate oral therapy for these patients, which is very often helpful. So I would typically prescribe doxycycline, 20 milligrams twice a day for a month, and then I'd go to once a day indefinitely. And I also began to explore nutritionals, and eventually had an epiphany. Actually came from Eric Donenfeld, who's an old mentor and friend of mine, and we've switched to PRNDE, which is a profit center for the practice. Great for the patients. We carry it and we offer it to our patients. It's important to recognize that there are differences between different omega-3s. The triglyceride form is the most bioavailable and potent, and that the stuff that they buy in Costco has a fraction of the potency of the quality products. And the quality products are PRN, which is sold through doctors' offices, or Nordic Naturals, which can be purchased in health food stores. The typical diet that patients have is so deficient in omega-3s these days that it's really problematic, not just from an eye perspective, but from a health perspective in general. So if you're getting patients to be taking a functional amount of omega-3, you're doing them a major favor. The reason why we see so much MGD, the reason why it's literally exploding these days, is because, number one, patients aren't blinking. We're sitting in front of computers all day. We're reading constant input of information. Blink rates are down. And also because our diet is so miserable. It's high in omega-6s, which cause increased saturation and problems with lipid production. So we now have therapy. You have discussed this with the patient, you've reviewed everything with the patient, you want to establish treatment. And I know many of you are saying, well, I just use warm compresses and I have them massage their eyes. And I will tell you, warm compresses don't do anything. A warm compress isn't a bad idea to cleanse the eye because of that soap issue, that soap making an MGD, but the heat does not transfer through the lid. The lid is an air conditioning system to maintain relatively stable temperatures at the corneal level. And it's very effective at doing that. When you use a warm compress, not only does it cool off before you get it to the eye, but it also doesn't penetrate to the level of the meibomian gland, so it doesn't melt these thick, saturated oils. So we typically use warm heat technology. The Bruder mask is one example. Tranquilize Eye Echo makes a number of products now in addition to their Tranquilize that are similar to the Bruder mask. And warm, moist heat is very, very effective. It makes the patient feel more comfortable, at least from a comparison to the warm compress perspective. So it's certainly better than a warm compress, and it's better than nothing. It may not clear obstructions in fairly advanced MGD, but I tell the patients, as long as we're getting a little bit of melting at the core periphery of the meibomian glands, basically you have like a cylinder of wax. As long as we melt the periphery and it's mobile, then I can express it later on. It helps express it. I mentioned before that blinking was a major factor for these patients, and blink training is important. This can be accomplished by simply telling the patients that they need to blink on a regular basis, but even better by either giving them a handout, and you can download one from the internet, look up Corb Blink Training, KORB Blink Training, who really is the originator of this technique, as well as one of the great minds when it comes to meibomian gland dysfunction. He probably is the greatest thinker of our time in that area. He offers for free, actually through Tier Science, a app for iPhone. Unfortunately, there is no app for Android at this point, but my iPhone users use it. It reminds them to use to blink, and also gives them instructions. Lid debridement, as I mentioned before, is important. This is a golf club spud, and you can see the line of marks is being removed. Normally I would stain that with Lissamine green, and you can see all the heaped up junk. Now that creates a mountain that meibum can't cross. It also blocks the glands, and that's an important step before anything else to clear the obstruction. Blefax is a relatively new and not overly expensive technique, which is great for blepharitis, but also we use almost exclusively, I shouldn't say exclusively, we use extensively for lid debridement. It's very, very effective. Patients say it tickles a little bit, but it does an amazing job. And for intractable blepharitis, we have all this just baked on gunk. It's very, very helpful. Now, clearing the obstruction is very important. So these patients are on an omega-3, a triglyceride form, PRN, and I tell them it's going to take 6 weeks to 2 months before it works. So I try to get them to buy a 2-month supply because I know it's going to take that long to work. And I also give them Avenova, tell them they need to use it morning and night. The Avenova begins to produce effects very, very quickly. The patients are much more comfortable, the tears are much more stable, and there are some patients that feel great. If the patients have really abnormal meibography, I tell them that this is going to make you feel better, but we need to clear the obstruction because that's the only way we're going to improve the condition long term. So expressing the glands is important. I wish that I had the success that you saw here with every patient, but the sad part is manual expression is not that easy for these patients. Very little comes out in many of them. And I have a number of different ways that I attempt to express them. Mastrota paddle is what I use most commonly. It was invented by Kathy Mastrota, who's an expert in her own right on meibomian gland dysfunction. The Ureta forceps need to be used carefully because they can be painful, but they can be effective, although it takes a while to apply them properly. And the Collins forceps are somewhat problematic because of the large surface area. They have to be applied gingerly because they can be painful, but they can be effective. The definitive treatment for meibomian gland dysfunction is LipiFlow, and we have LipiFlow in the office, as I mentioned before, and this can be transformative for patients, literally life-changing. What's neat about LipiFlow is that it heats from the inside rather than from the outside, so there's no wicking away of heat, raises the temperature of the glands to the point where the meibum melts, it completely liquefies, and these silicone pads compress fairly vigorously to empty out the glands completely, and it kind of resets things. Patients feel at the end of it it's spa-like, it's not uncomfortable at all. Inserting the activators or disposables is not difficult, and most patients feel quite comfortable, so there's no issue with that. I tell patients that this is so effective at emptying the glands out that it's going to take probably 2 to 3 weeks before enough oil is built back up in the reservoirs, because the meibomian glands are not just production centers, but they're also storage tanks, before you get enough lipid to stabilize the tears. But it works for about 90% of patients, and we've been very, very happy with it. It lasts in almost every patient for at least a year, and in some cases goes well beyond that. So we've been fairly successful with this, and as I mentioned before, in some situations life-changing. So I think this is important, but more important is understanding that this is an ongoing issue. So again, just to review, identify, diagnose, engage the patient in understanding what the problem is, recognize that lid disease, that meibomian gland dysfunction is a driver for massive amounts of misery and decay, very much like the dentist's face, and recognize that this needs to be dealt with to the point where the patients are stabilized, where the cavities are filled, where the teeth are cleaned, so the patient is stable, and then the patients need to be educated so that they come back every 6 months, the same way they go to a dentist. The dental community has been so effective in convincing patients of the need for ongoing oral hygiene. We need to take a page from their book. We need to convince patients that they need to come back to us every 6 months so we can debride the lids and clear the meibomian glands and express if necessary. We need to do imaging once a year the same way they take x-rays. We need to do meibography once a year and evaluate tear film stability with non-invasive breakup time and engage them in that. And they need to do home therapy the same way they brush their teeth. They need to clean their lids. They need to use Avenova to address lid issues. And the analogs are relatively clean. Toothpaste and brushing is Avenova. Routine cleaning is debridement with the Blefx or with a golf club spud. Deep cleaning, LipiFlow, or manual expression. Imaging, Keratograph. It has a number of different imaging technologies built into it. And they continue to improve this, by the way. So we get updates, and things are constantly changing for the better in terms of our ability to diagnose patients. Flossing is warm, moist, heat, and obviously nutritional support is PRNDE, triglyceride-based omega-3. So the dental model can literally transform eye care for us as ODs as well as for ophthalmology. It's something I think we all can agree on. Patients are already programmed for it. Now, one of the things I think it's important to realize is that these are out-of-pocket expenses for the most part, and I'm not being mercenary or pecuniary. There was a time where patients paid for care. I do believe in safety nets and all the other things that go along with an advanced society. We need to take care of people who are ill, but people also need to be responsible, and our practices need to survive. If our practices are not viable and they are not financially successful, we cannot provide care for these patients. So providing care that's not covered, and patients say, well, is this covered? Well, meibography is not photography. There is no code for meibography. There is no code for lid debridement. You can't bill for what there is no code for, although you certainly could put it on as a non-covered service, but it's going to be bounced. So the point that I'm making is the dentists have been very successful at it. Optometry will survive, it always has, but optometry needs to become more ingrained in this critically important issue because it's growing as a problem. We see more and more young people with significant dry eye and patients that are really miserable because of it that we can intercede and make a significant difference for. So if anybody has any questions, please ask away. If you want to email me and you have any questions, just send a note to artepstein@gmail.com. That's the easiest and probably the most reliable. So it's no spaces or dots, artepstein@gmail.com. I also want to thank Oculus for their kindness in sponsoring this. This is a great company. They are really at the very cutting edge in terms of technology, and they've been wonderful with supporting education well beyond the focus of their instruments. They make some really amazing things, and they're constantly improving it and tinkering with it. So I want to thank them, and I want to thank you, and I'll just stand by for any questions.
Thank you very much, Dr. Epstein. We do actually have a few questions here if you have time.
Sure, absolutely.
First question here. Would you recommend LipiFlow on a patient that has a large amount of meibomian gland dropout, say a grade 3 or grade 4?
Good question, and the answer is yes for two reasons. Number one, we have nothing else to offer them, and if we don't do something, they're not going to get better, they're going to get worse. So even if they have significant loss of meibomian glands, and we have a number of patients like that, even though they may not get significant relief from it, most of the patients do get some, and I think that's important. The other side of the coin is that unlike Donald Korb, and I absolutely revere Donald Korb. He's not only my mentor but my hero. But we don't always agree. Rather, we rarely disagree, but we don't always agree. So I have a number of cases where clearly there has been significant recovery of meibomian glands. And I am just waiting for one more to have a series of 3, and I'm going to publish the data. I've actually published photos of that in Optometric Physician, where you can see half the glands were gone, and 4 months later, all the glands were back. And it wasn't a technical miscue. It was the same technician who took the image, and we've had another patient with exactly the same thing, and I think there are more. I just haven't gone through all of the Meibography images to really look closely at it. But I do believe there is recovery, so it almost behooves you to attempt to recover whatever you can. So the answer is yes, I definitely would.
Okay, so I'll try to save what's there and hopefully recover. So we have a couple other questions here. I have a doctor that asks, what is the minimum I need to set up a dry eye center?
That is a phenomenal question. Number one, your fingertip. You need a fingertip that's calibrated to mimic the pressure of a blink, because diagnostic expression is important. You need a slit lamp. If you can't do Meibography, and by the way, and this is not meant as a commercial comment, but in the sense it is, if you have an old topographer that's falling apart, for the cost of a topographer, you can have a dry eye testing suite. So that was a decision we made when we opened the practice. We knew we were getting a topographer, which is why we bought the Keratograph 5M, because it incorporates topography, really good topography, by the way, with this extensive dry eye testing suite. But fingertip, slit lamp. Now, Meibography can be accomplished by looking directly with a fair amount of experience, but also by transillumination. So using a transilluminator can actually give you not a great view of the glands, and certainly not one that you can share with patients, but it's certainly usable for establishing a diagnosis. I think you need a Mastrota paddle for treatment as a minimum. I would also recommend that diagnosing is great, but you need to get involved with treating. So a nutritional, PRN is my recommendation. It's what I use. There are other products on the market, so I certainly, would not fault someone for selecting something else if they think it's beneficial or they're comfortable with it. I've just had really good luck with PRN, or I should say my patients have. Avenova, there's nothing like it. There's nothing even remotely like it. It is pure hypochlorous acid in saline. Hypochlorous acid is secreted by neutrophils. It doesn't damage tissue. It's completely non-toxic. I can't say that for all of the similar products in terms of toxicity, at least looking at cell cultures. And patients absolutely love it. In fact, we started really getting turned on to it when we realized that patients were freaking out because when we gave them samples, they were afraid they couldn't get more, and that makes a difference. Heat masks, the Bruder or the Eye Echo masks, and take a look at Eye Echo and see what their newest products are. Having those on hand and being able to do expression, use Avenova, use PRN is really what's going to make a difference for the patient. I didn't mention one thing, which I'll mention now. When you have a patient who has exposure, I know the traditional therapy is ointment. What we do is we use the sleep shield. It's called the Onyx Sleep Shield. In fact, they just came out with a new one. I'm waiting for samples. This is Eye Echo, which is a company in California, and it creates a moisture barrier. So the eye is just completely protected by this silicone shield, and when the patient sleeps, a mild gel usually suffices, and these are patients that have significant exposure, so this is very, very helpful for those patients as well. So carrying those things and providing them to patients really is one of the things that will differentiate you and get you started in dry eye. Certainly all the other equipment is great and will make you more precise and more effective at diagnosis and treatment, but you certainly can get started with pretty much what you have and a couple of other instruments as well.
Okay, thank you. I think we have time for one more question, if that's okay.
Sure.
I do have a doctor that asks, do you have a screening process to catch asymptomatic dry eye, and how do you engage patients that are asymptomatic to get them to comply with treatment recommendations?
That's another great question. These are really very, very astute questions. And the answer is it's very difficult. Patients come in generally either because of a sense of duty, they know that they're due for their checkup, or they come in with a complaint. Very rarely does a patient come in who's asymptomatic and you share something with them that motivates them without some effort. Glaucoma patients being a perfect example. Mrs. Smith, I've just diagnosed glaucoma. This is a very serious problem, and you can go blind if we don't treat it. We need to treat it, and here's what I want you to do. I want you to take drops, and I don't have to tell you, you know exactly what compliance is with glaucoma. It's certainly less than optimal, even for fairly intelligent patients. So in a situation like this with dry eye, if you're going to be successful, you need to reinforce how significant it is, and that dry eye is a progressive and disabling condition. I think that if you use things that reinforce behavior, and again, I hate to harp on Avenova because it produces such a direct response. It's such a valuable tool, and patients feel better so quickly and so dramatically that it helps reinforce that treatment. The problem with drops, and I probably don't have to tell you because you asked the question, the problem with drops is patients go through drops and very rarely do they stick. There are some drops that are more effective at sticking or stickier than others, sustained balance being one of them, fresh coat being another one, which is one of the reasons why we use it. But if you use things that make a difference for patients and are very interactive with them and ask them if they've gotten benefit from it, that will reinforce the use of it. But it's an uphill battle. There's no question that it's an uphill battle, especially when they don't see that. The last thing I'll say about that is if the patient has something physically wrong with them, for example, meibomian gland dysfunction, and that's the root cause of their dry eye, showing them their meibomian glands and telling them even though they're asymptomatic, they have a problem that needs to be addressed is a very, very powerful tool. When they see missing meibomian glands and they compare it to a normal, patients are much more apt to follow directions and are much more engaged in managing their own condition with you. So I think it can work, but again, it's much more difficult than for a patient who's symptomatic.
Okay. Thank you for that, Dr. Epstein, and thank you for the excellent presentation and taking the time out of your busy schedule to be here tonight. I'd like to thank everybody else as well for attending. If you would like to view past Oculus webinars, you can visit our website, www.oculususa.com, and go to webinars. It's on the lower left corner of the page. If you have questions or comments regarding tonight's webinar or any other webinars, you can also email us at sales@oculususa.com. And with that, I will wish everybody a good evening. Thank you again, Dr. Epstein, and everybody have a safe night.
Thanks, Chris. Thanks, everyone.